Hi, my name's Scott. I'm going to be doing a physical assessment on my dad here, Bob. My mom is the cameraman, Dina. Thank you, Dina. So what I'm going to do is I'm going to start by introducing myself, washing my hands first. Hi, my name is Scott. I'm going to be your nurse practitioner, and I'm going to be doing a physical assessment on you. How have things been?
Good.
Um, I, can I start by actually asking you your name and your age?
My name is Bob. I'm 59.
Good. Have you had any recent health issues?
No.
Okay, so I can see that the patient is alert and oriented. He has proper gaze, good posture. He has symmetric strength and balance, being upright while sitting, and appears comfortable and not in any distress. So what I'm going to start off with is I'm going to be just doing a skin assessment visually. I can see that there is no discolorations, masses, lesions of any kind throughout. Have you had any skin issues lately?
No.
No. Well, I'm going to start with the scalp. Or rather, I'm just going to palpate the skin here throughout just to see there's warmth. There is no, it's dry, skin turgor is appropriate, and you can see that there is a good less than 3 seconds blood return to the fingers, coming down to the legs here, still no moisture, dry, appropriate turgor, and also less than 3 second blood return here. And then I'm going to proceed actually from head to toe, beginning with the scalp. Have you noticed any issues with your scalp lately?
No.
No skin dermatologic issues,
No.
things like that? No. I can see that the hair is evenly distributed and that there is also the skin is appropriate to ethnicity with no discolorations, masses, or lesions. I'm going to palpate your skin now if you don't mind. Okay, so it does in fact feel round with proper contour bilaterally. I'm actually going to palpate down here at the temporal artery. Do you notice any tenderness here?
No.
Good. So there's no temporal arteritis. What I'm going to do now is I'm actually going to inspect your eyes. So have you had any difficulty seeing?
No.
No? Okay. I can see that the eyebrows are symmetric, as are the eyelids. The conjunctiva is pink, moist, with no erythema, and the sclera is white. What I'm going to do first is I'm actually going to cover your eye here, one eye, and I'm going to do a test called the cover test, where I'm going to have you follow my finger like this, inward. And I can see that both eyes are following each other. One eye is not deviating from the other while covered. So the cover test is a negative. What I'm going to do now is I'm going to test for cranial nerves. I'm going to defer the Snellen test, which is cranial nerve 2, and I'm going to test for cranial nerves 3, 4, and 6 with the cardinal directions of gaze here. This will also test the patient's accommodation and convergence. So what I'm going to do is I'm going to have you not move your head, but follow my finger. Good. I'm going to bring it closer. Now I want you to look over my shoulder. Good. So there's appropriate accommodation, which I can see by the patient looking over my shoulder, as well as convergence as I bring my finger forward. And he followed my finger throughout, indicating 3, 4, and 6 are all intact. What I'm going to do now is I'm going to assess the patient's pupillary constriction. I'm going to be shining a light in your eye here. There we go. So I'm going to do both the indirect and direct. So just look straight forward. And then direct. Good. So I can see that there is consensual constriction on both pupils, which is equal, brisk, brisk bilaterally, +2 to light. What I'm going to do now is I'm going to inspect your eye, both the surface and the interior eye, using starting with 1 in order to assess the surface and proceeding further to inspect the interior. So just continue looking straight forward. I'm going to look from over here. Good. Good. All right. So the exterior eye is symmetrical, rounded, intact, and the interior of the eye displays a positive red reflex as well as an intact optic disc, which is orange, and also the optic arteries are intact. It's not bleeding. So good here. We're gonna move on to the ears. Have you had any difficulties hearing?
No.
Good. So I can see visually that both ears appear symmetric. I'm only gonna focus on one ear for the purposes of this video. But what I'm gonna do first is I'm gonna test cranial nerve 8 by doing what's called the whisper test. So can you face this direction for a minute? I'm gonna come from behind you and I'm gonna whisper a 2-syllable word and tell me what it is.
Apple. Apple.
Okay, I'm gonna do another one.
Grape.
Good. So cranial nerve 8 is intact. Yes. What I'm going to do now is I'm going to inspect the ear by palpating it, and I want you to tell me if there's any tenderness here. You can face this way now. I'm going to palpate the mastoid.
No tenderness.
Good. The pinna.
No.
And the tragus.
No tenderness.
Good. They all appear intact. What I'm going to do now is I'm going to inspect the bone and air conduction of both ears by using the Weber test. So I'm going to put this on top of your head, and I want you to tell me when you stop hearing it, or if you can hear it rather.
Yes, I can hear it.
Good. Okay, so the Weber test is positive. I'm going to do this. I'm going to do the Rene test, which tests the conduction of the bone and the air conduction function of your ear, your unilateral ear. So I'm going to do it. Tell me when you can stop hearing this. Now tell me, can you hear it?
Yes.
Tell me when you can stop hearing it.
Now it's stopped.
Okay, tell me when it stops now.
Now.
Good. Perfect. So the air conduction was twice as long as the bone conduction, which is normal. So moving along, I'm going to take a look at your nose. Have you had any difficulties smelling?
Nope.
Do you have difficulties breathing out of one or both sides of your nose?
No.
No. Well, I can see that the patient definitely breathes through his nose, is not a mouth breather, and that the nose is symmetric visually, and that it is patent. So what I'm going to do is I'm going to palpate the sinuses. Can you just tell me, I'm first palpate the frontal and the maxillary after that. So just tell me if you feel any tenderness.
Nope.
Okay.
Nope.
Good. So I'm going to feel the nose, and it definitely feels midline and patent. So what I'm going to do is I'm going to illuminate both the sinuses and then the nares to inspect to see if they are indeed intact and normal. And frontal and maxillary sinuses are definitely not enlarged and appear normal on illumination. And take a look in the nares. Can I have you just look up for me? Good. You can see that there is no septal deviation. It's definitely intact, and the tubernates are also intact. Coming down to the mouth, I'm going to test cranial nerve 7 here So I'm gonna have you smile, frown, and then puff out your cheeks. Perfect. Can I have you stick out your tongue? Good, that's cranial nerve 12, that's also intact. Have you had any soreness of the throat?
No.
Okay. Have you had any dental work lately?
No.
No. All right, perfect. So what I'm gonna do is I'm gonna actually look inside your mouth as well. Can I have you open your mouth, stick out your tongue, and say ah? Good. I see that the soft palate and also the uvula rose midline, which is indicative of intact cranial nerve 3, 4, and of 9 and 10, and also the tonsils were, and also the tonsil pillars were intact. The tonsils were +1. I saw that the Stenson's duct was intact with no stones. However, I need to take a look at the Wharton's duct, which is under the tongue. Can I have you raise your tongue and open your mouth? Good. Wharton's duct looks good. It's intact, no stones. Moving along to the neck here. I'm gonna actually I'm gonna take a look at your. I'm gonna take first a look at your head and shoulder strength here. Can you push against my hand here and also on this side, and then shrug your shoulders? Good. So cranial nerve 11 is intact, and it's good. +5 shoulder strength here. But coming down to the neck, have you noticed any new swelling of any kind?
No.
No, not on the neck at all?
Nope.
Okay, I can see that the neck is upright, midline, as is the trachea, and that swallowing seems normal. What I'm going to do first is I'm going to palpate your lymph nodes, starting with the pre-auricular, post-auricular, tonsillar, submandibular, submental, anterior cervical, posterior cervical chain, and the infraclavicular, and the supraclavicular. So, do you notice any tenderness anywhere there?
Not at all.
No, and I didn't palpate any lymph nodes, so those are with the normal limits. What I want to note also is that there is no pulsation of the carotid artery, and on feeling the carotid artery, it is a +2. But what I'm also going to do is I'm going to auscultate it for any bruits, and also auscultate the thyroid. So for any bruits, which should not be there. No. And no. So that is normal. So I'm gonna display how I would visualize the jugular, but I'm not gonna do the jugular. I'm gonna talk about how to measure the jugular pressure, but so I'll display how to visualize it. Can I have you lie down? Patient should lie at 30 degrees. And can I have you turn your head that way? So turn a little more. Good. I can kind of see it right here. That's how you get it displayed. But what you would do to actually measure it is you would measure it from the sternum to the most cranial point of up and towards the most cranial point of the carotid artery, and the distance above the sternum to level with the carotid artery. You'd add 5 to that, and that would be the pressure, which should be between 4 and 8. But moving along, I'm going to take a look at your respiratory system. Can I have you lie or sit up again? Thank you. Have you had any difficulty breathing lately?
No.
Do you have any history of emphysema, smoking?
No.
Okay. What I'm gonna do is I'm gonna take a look at your back here. And so what I see is, I don't see any difficulty with the patient breathing. He has bilateral chest expansion. He is comfortable, definitely comfortable breathing, and it's a regular rate. I can see that there's no accessory muscle use. And so what I'm going to do is I'm going to palpate for any tactile fremitus. So what I want you to do is I want you to say 99 every time I move my hands.
99, 99, 99.
Can I actually have you turn that way a little more?
99.
Okay, just to be sure, I put my hands here in the middle of his back. So there was no hyper resonance, so that indicates that there is no consolidation. What I'm going to do now is I'm going to listen. So every time I move, before I listen, I'm going to percuss. And there shouldn't be any hyper resonance when I percuss. So let's do it between the constant the you know what, I really probably should have them be able to see. Can I have you sit here? Perfect. Okay. While I'm here, I'm going to test, see if there's any costovertebral angle tenderness. Does this hurt?
Nope.
Right here?
No.
No. Okay. So I'm going to proceed by auscultating the lungs here. So every time I move my stethoscope, I want you to take a deep breath. So lungs are clear bilaterally. Just to point out that this is the vesicular region, this is the bronchial region, bronchiovesicular region, and the vesicular region, which is the base of the lung, which is the most important. This is where you hear the most pneumonia, if there is any. So I'm going to come to the front now. I actually have you turn around here. Sit down. Yeah, right there. I'm going to listen on the front. Breath. Again. 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 And again. And one more time. Okay, great. Lungs are clear bilaterally. So I'm going to move on by doing tests to test just 3 tests for testing lung consolidation, bronchophony, egophony, and also whispered pectoraliqui, which in this case is what I'm going to use. We can use one for the rubric. So what I'm going to do is I'm going to have move again, just like right here. Perfect. Whispered pectoraliqui requires that you have the patient, you listen to the patient and have them say either 99 or 1, 2, 3 and whisper it. And if you have hyperresonance, then if you can hear really well, then that can indicate consolidation. So I'm going to have you say actually 1, 2, 3, whisper 1, 2, 3 when I move my stethoscope. no issues with, there's no hyperresonance, so that was negative. So I'm gonna have you move back to the couch here. We're gonna move on to the cardiac section here. So have you had any issues with palpitations lately?
No.
Do you have a history of any sort of cardiac related issue,
No.
pacemakers, anything like that?
No.
Okay, so on inspection I can see that there's no pulsatile areas of the chest here. I don't see the PMI or anywhere on the chest. So what I'm going to do is I'm going to palpate the PMI at the mitral, the area of the mitral valve, which is at the midclavicular line, the fifth intercostal space, and I can feel that there is the I can feel the pulse of maximal, the place of maximal, point of maximal impulse, which is just normal. What I'm going to do is I'm going to listen to each point with the bell and the diaphragm of my, what I would do is listen with the bell and the diaphragm of my stethoscope to each point on the heart for 30 seconds. I'm going to defer the 30 seconds because for the purposes of this video, we'll do 5 points, the first being the pulmonic valve, which is at the sternal border at the second intercostal space. Herb's point, which is fifth intercostal space, sternal border, or fourth, excuse me. And then at the second intercostal space, this is the tricuspid, or excuse me, the pulmonic valve here. The second intercostal space, fourth intercostal space, sternal border. This is the tricuspid valve. And then over at the mitral valve, fifth intercostal space, midclavicular line on the left side. Okay, good. So they're all very much intact. There is no murmurs, tics, things of that nature. But what I want to do also is I want to assess for mitral stenosis and aortic murmurs. So what I'm going to do is I'm going to have you actually lean forward and exhale. Good. No mitral stenosis there. I didn't hear any clicks or anything. So I'm going to do the aortic valve here, and I want you to exhale again. Good. No aortic murmurs. And that's it for the cardiac section. So I'm going to move on to the abdomen here. So I'm going to have you lie down. Have you had any abdominal issues such as constipation or any kind of constipation or anything?
Nothing.
No.
None.
Okay, so I see that the abdomen is rounded. It's symmetrical. There's no areas of pulsation, masses of any sort. So what I'm going to do first is I'm going to auscultate for the bowel sounds which should be present. Good. I'm going to auscultate also the abdominal aorta, which, for any sort of bruits, which should not be present, as well as the renal arteries, which are not present, and the iliac arteries. They're also not present. So what I'm going to do now is going to move on to percussion. There should be timpani here when I percuss. So we'll start here. there's tympany throughout, which is normal. So now I'm going to start with palpation, starting with soft, proceeding to deep. So let me know if you feel any tenderness.
Nope. 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 Nope.
Okay. I'm going to move on to deep palpation. Let me know if you feel any tenderness.
Nope. 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 Nope.
Good. So I'm going to start palpating areas of locating different parts of the organs of the abdomen here, different landmarks rather. First, I'm going to come over to McBurney's point here and palpate it deeply. Do you feel any tenderness?
Nope.
Okay, this is known as Bloomberg sign, and it is negative, which means that this patient is negative for peritonitis and also appendicitis. I'm going to come on over to palpate the kidneys, if I can, which I cannot. Good. I'm going to try to palpate the spleen, which I should not be able to. Come over here. Good. Then I'm going to palpate for the liver here, which definitely should be able to, but I'll have you take a deep breath in. Can you? Good. So I can feel it just there. So it should be between 4 and 8 centimeters here. That's about right. So what I'm going to do now is I'm going to just palpate do some of the abdominal maneuvers here, examining for peritonitis and appendicitis and cholecystitis, things like that. So I'm going to come over and do Robsing's sign here, which is for appendicitis. Do you feel any tenderness?
No.
Good. And then I'm going to do Murphy's sign up here. So take a deep breath in. Any pain?
Nope.
No. He did take a deep breath. He noted no pain. So that's negative Murphy's sign, negative for cholecystitis. I'm going to come down. I'm going to palpate the bladder here, which, do you have any tenderness?
Nope.
No. The bladder is not tender, and it's not, I can't palpate it, so that's normal. I shouldn't be able to palpate it. But I'm also going to do one more test for appendicitis, known as Soas' sign. I'm going to have you, can you have you lift this leg here? Any pain?
No.
No. Is there any pain in your lower back?
No.
No. So he doesn't have pain with raising this leg, meaning that he doesn't have appendicitis, but he also doesn't have a lower back injury. If he had a lower back injury, he could also sometimes have pain associated with the opposite leg, which would be ipsilateral pain, which might indicate a slip disc. So I'm going to assess for the obturator muscle here. So I'm going to have you bring your leg up and bend it, and then I'm going to kind of twist it this way. Do you have any pain?
No.
No. Okay, and obturator muscle is present and strong. So I'm also going to assess for the patient's presence of meningitis. What I'm going to do first is I'm going to have you bend both knees up, just like this. Does this have any pain associated with it?
Nope.
No. So that indicates that that was a occurring sign, which indicates that's negative. And then I'm going to have you lift your head like this. Does this cause any pain?
Nope.
No. Good. So Burdinsky's sign is also negative. Coming down further, before I continue proceeding down to the knees, I'm going to assess the patient's arms for any rotator cuff injuries and wrist injuries. Can I have you sit up again? Now, have you had any injuries to your arms at all lately?
No.
Okay. So I can see that his arms are definitely, one is not sagging more than the other. Definitely has had strength throughout this examination for sure. but I'm gonna start by testing his shoulders. So I'm gonna have you bring your arm out like this. And then I want you to kind of slowly drop it towards your side. Okay. So there wasn't any sudden drops, meaning that his rotator cuff is intact, but there's a couple more tests for that. What we're gonna do now is the near test. So we're gonna do some kind of like a backstroke. I want you to put your hands inward like this and kind of extend them if you can, and then bring them up to your head like that. Does that hurt?
Nope.
No. Okay. So the near test is also negative for any sort of rotator cuff injury. And the last being the Hawkins test. So I'm gonna have you put your arm like this and kind of bring it up like this. I'm gonna push it in like that. Does that hurt?
No.
No. Okay, Hawkins test negative, also negative for any rotator cuff injuries. So we're gonna proceed towards is assessing the hands here. So have you had any injuries to your hands, anything like that?
No.
Can you wiggle your thumbs like this? Good. Thumbs have good proprioception here. Also, when I was examining his arms, he had +5 strength, but we're gonna examine the rest of them. So we're gonna examine Tinel sign. Can I have you bring your hand up just like this and then extend it like that? I'm gonna tap on it like this. Does this cause pain?
No.
Good. So that's negative for carpal tunnel syndrome. Can I have you take your thumb like this and grab it like this? Turn it like that, and then try to pull it forward a little bit like that. Good. Does that hurt?
No.
No. Also negative. That was Finkelstein's testing also for carpal tunnel syndrome. The last being Phelan's test. So can I have you put your arms like this and then bend them like that? Try to like pinch your arms together like that. Good. Does that hurt?
No.
No. So Phelan's test, also carpal tunnel syndrome, negative. So we're gonna test the strength of the arms here, the rest of it. Can I have you grab my fingers and squeeze them? Good. We do the some range of motion here. Can I have you supinate your hands like this and pronate them like that, and then evert them like this and invert them like this? Now I want you to kind of bend, spread your fingers out like this, and then put them together. Good. I want you to push down on my hands and then push up. Okay. Now I want you to try to crunch my hands toward you. Sorry. I mean like this.
Oh.
Like crunch, sorry. Up towards you. Perfect. And then out. Good. All right. +5 strength throughout. We're going to come down to the legs here. I'm just going to kind of finish off the arms while I'm here, though. I'm going to take pulses. This is the radial pulse, which is +2. Brachial pulse, +2. Carotid pulse, +2. So I'm going to have you lie down again. Have you had any difficulties walking?
No.
Any surgeries of any kind lately?
No.
No. Okay. So I can see that the knees are definitely symmetric, bulging on assessment. They're definitely they definitely look intact. So what we're going to do is I'm going to first do the McMurray's test. And I'm gonna have you kind of bend your leg towards you, and then I'm gonna push it inward like this. Okay, so this is testing for minuscule tears. Did you notice any tenderness with that?
None.
No, so I didn't notice any give of any kind, so that's negative. What we're gonna do now is we're gonna do the drawer test, anterior and posterior. I'm gonna bend your knee again, and I'm gonna sit on your foot. I'm gonna push. So this is for the ACL here, the drawer test. I'm gonna push on it to do an anterior drawer test. And there's no give, so that's negative. And then I'm gonna pull for a posterior drawer test. So that's negative. ACL is intact. What we're going to do now is test the LCL and ACL here. LCL and MCL rather. Now for the MCL, this is the valgus test in which we push outward like this, and there is no give, and that means that it is a negative and that the LCL is intact. The varus for the MCL, I'm going to do the same thing, but I'm going to push inward while holding the knee, and there is no give, so that is also negative. It's intact. We're going to take a look down at the feet here. Have you ever had any? Have you ever had diabetes?
No.
Have you ever had any sensory difficulty feeling anything in your feet lately?
No.
No. Okay. What we're going to do is we're going to do some diabetic tests for the feet here. Starting with, I'm going to do actually a toe proprioception here. Can you wiggle your toe here? Good. You got good flexion and extension of the toes here. But what I want to do is I want to inspect to see if there's good sensory sensation here. Can you feel me okay?
Yes.
Good. Feet look, the skin on the feet is definitely appropriate to ethnicity, with no, and the skin's intact, no discolorations of any kind. And testing for the sensation of the big toe, I just want you to tell me if you can feel this.
Yes.
Good. So the toe definitely has good sensory perception. What I'm going to do now is I'm going to test the toe with the filament test. My filament, I lost mine today. I'm going to use this one here. So I'm just going to, I want you to feel this. This is what I'm going to be putting on your toe, and I want you to tell me if you can feel it when I put it down, okay? Mm-hmm. Okay, big toe, feel that?
Mm-hmm.
Little toe.
Mm-hmm.
Good. Okay, microfilament test is positive. So what we're going to do now is I'm going to inspect a little better the just making sure we got all of this. I'm going to inspect a little better the cardiovascular system of the patient. When I was up at the upper extremities, I should have looked at and mentioned the patient's, if there's any, how the pallor was, asked if the patient had any lack of sensation, and also noted if there was any edema, which there is not. Same thing goes for the lower extremities here. Now I palpated the upper extremity pulses, but I'm going to come down to the lower extremities here and palpate first the posterior popliteal pulse, which is +2. Now the pedal pulse, or the pedal pulse here, and the posterior tibialis is also +2. Okay. Now we're going to do some range of motion with the feet. Can I have you sit up a little bit? I'm going to start with the strength here. I'm going to have you push up on my hands and push down. I want you to push out, in. Now I want you to dorsiflex your feet up and down. Good. Now I want you to try to extend your leg out like this all the way, if you can. Good. So it's got good range of motion with the knees here as well as the feet. And I have you just kind of rotate your ankles around. I know your ankles are kind of not that mobile, but ankles and knees definitely have full range of motion here. We're going to do the hips when we're standing, but before we do that, we're going to start with some cerebellar tests. What we're going to do first is some 2-point discrimination. And before we do that, one cerebellar test that I want you to do is called rapid alternating movement. So I want you to do this with your hands on your knees and rapidly. Perfect. Passed it. Now this is the soft versus sharp test. So I want you to close your eyes. This is sharp and this is soft. I want you to tell me which one you feel.
Sharp. Soft. Sharp.
Perfect. We're going to do 2-point discrimination next. So this is 1 point, and this would be 2 points. I want you to tell me which one you feel.
2 points.
Mm-hmm.
2 points.
Mm-hmm.
2 points.
Mm-hmm. Perfect. So, passed both tests. What we're going to do next is called stereognosis and stereesthesia and graphesthesia tests. And what it does is essentially, I'm going to start with stereesthesia, where I put a random object in his hand and he tells me what it is. So just close your eyes and put something in your hand when you tell me what it is.
Keys.
Yep.
A key.
Perfect. We're going to move on to graphesthesia. In this one, I'm going to write a number on your hand. I want you to tell me what number it is.
3.
Perfect. All right. So what we're going to do next is we're going to do some balance testing. I'm going to have you stand. I'm going to finish actually off the range of motion in the hips. I want you to bring your knee up and rotate it outward and then back. Good. It's good rotation as well as extension and flexion of the hip. But what we're going to do is we're going to do the Romberg test, in which I'm going to have you stand while your eyes are closed for about a minute. We're going to defer the minute and just watch for swaying, any kind of loss of balance, which is negative in this case, so we're good. We're going to test for balance now. I'm going to have you walk towards the wall, and then I want you to walk back but on your heels. And good, balance is excellent, gait is excellent. What we're going to do is I want to do the the Trendelenburg test. That will, in order to do that, I want you to actually stand on one foot. Actually, stand on one foot facing that way. Good. And on the other foot now. Okay. There was no step off from the hips, so that indicates to me that there is no hip. That Trendelenburg test was negative, and that the patient doesn't have any hip weakness. Okay, so after that, I'm gonna have you do one more test here. I want you to sit down. This is the heel to shin test, and all I want you to do is another cerebellar test. Is I want you to put your heel to your shin, and then actually go down your leg like that. Do it. Yeah, perfect. Now do it with the other foot. Good. All right. So that concludes the test. I would just let my patient know the results of it, what I think, and wash my hands and exit the scene.